Thank you. Well, thank you to everyone who is here. I know we're in kind of an interesting time with this virus, and I appreciate that people are still making the time to attend our presentation and engage in professional development. And I also see it looks like we're kind of a small enough group, we should be able to have a little discussion afterwards and some Q&A. So just to quickly introduce myself, and then I'll let my colleague Brandi introduce herself. My name is Adrienne Lindsey. I'm the Associate Director for the Center for Applied Behavioral Health Policy. And if you're not familiar with us, we are a research and training center in the Watts College. And Brandi, did you want to say a bit about yourself? Oops, I
Sure. My name is Brandi Champion, and I'm the Supportive Housing Manager at Old Pueblo Community Services in Tucson, Arizona. And Old Pueblo is a specialty provider agency, and we've worked in conjunction on this grant with ASU.
Great. And we have partnered with Old Pueblo Community Services, we were just talking before everyone got online, for about 15 years. So we have a long-standing partnership. So today we're going to talk about our partnership to provide permanent housing for really kind of the highest need, highest risk homeless individuals, those with chronic health conditions, serious mental illness, substance use disorders, and sometimes a combination of those three things. So we'll talk about how we are collaborating to serve this population. So, you know, the larger problem we're trying to address is homelessness, specifically homelessness in Pima County. So both Brandi and I are located in Pima County. I work out of the ASU Tucson campus. Brandi, as she mentioned, works for Old Pueblo Community Services, and they have housing and behavioral health services all across Tucson and various sites. And our homeless challenge here in Tucson looks much like it does in Maricopa County and other counties. We have a lot of individuals living directly on the street, and a lot of chronically homeless individuals, you know, who've been homeless for 10, 15, 20 years or more. And so we're dealing with a very high risk, high needs population, in that they're often circulating through our jails, circulating through our healthcare system, and so on. So just a little bit about what the homelessness numbers look like in Pima County, for those of you who are here in our county. So we're going to break this down by population a bit. But if you look at overall total homelessness, that's your blue line there, you'll see that it's been declining, which is positive. We're certainly encouraged to see that. But if we break that out by, and we might need a few of you to mute. I think we're getting a little background noise. Not sure where it's coming from, but go ahead and mute your mics if you can. So we have some populations that are sort of hanging steady. If you look at the gray line, that's our emergency shelters. Largely, we don't see those numbers moving much. People are, you know, who go through the emergency shelters are largely staying homeless. If we look at our street count or chronic homelessness numbers, those are staying pretty stable as well. However, if you look at this PSH line, that is permanent supportive housing line, we are seeing a bit of a decline. And if you're not familiar with permanent supportive housing, what we mean there is individuals getting into their own housing, something that is permanent. This is often in the form of, say, their own apartment, and it's supportive in the sense that they may be receiving some financial assistance for that housing, and hopefully some wraparound services, and we'll speak to those. And we do see those numbers declining. So that's encouraging. We'll talk a bit about that model specifically. But we kind of have to lay the groundwork for sort of the history of addressing homelessness and kind of where we moved, for those of you that maybe don't work in this area. So how we've managed homelessness traditionally was we put folks into emergency shelter, and that's obviously a very temporary situation. We may try to engage them in some services that might be healthcare services, might be behavioral health services. Then we might transition them into what we call transitional housing, or if you think about maybe some of the older terms we've used, halfway house, things like that. And then we sort of hope that they move into this permanent housing situation. Maybe they do or don't have some income to do that. Maybe they haven't managed a landlord relationship in a long time. So those kind of become our fail points. People may leave shelter because they can't bring their pets in, or they can't have their partner with them, or maybe they're struggling to maintain sobriety, but they've got to take a breathalyzer to come into the shelter, things of that sort. And same goes for transitional housing. There may be a number of requirements that they're sort of struggling to abide by. Perhaps they need to get a job, maybe they need to pay for that housing to some degree. There might be various rules, house rules and things that they have to abide by, where we often see people leaving our programs. Now, if we look to the Housing First model, we really kind of flip that whole framework on its head and we say, okay, this person is homeless. We're going to provide them with a home first and foremost. We're going to put them right into their own home. So again, often that's going to be in the form of, say, their own apartment. Then we'll provide some supportive or wraparound services if those are needed, if those are desired by the person. They won't be mandatory for keeping their housing, but we're hopefully going to get them connected with healthcare, with behavioral health care, some form of subsidized housing for that permanent housing, and so on. And so what we see with this Housing First model is increased stability, and we see homelessness, particularly chronic homelessness, drop. And this is why we've seen HUD here nationally, and then also some international groups move towards this Housing First model, as we have this large body of research now to support it that demonstrates essentially when we give people a home without a lot of restrictions, we see homelessness go down and other areas of their life sort of stabilize. So if you don't know much about this model, I definitely encourage you to learn more. We have a number of resources at the end of our slide deck, but we won't spend too much more time on that today, but just a model to be aware of, and certainly the framework and foundation for this particular project. So if we look at some local numbers here in Pima County, if we take 100 people, place them in our emergency shelters, what we'll see is only about 21 of those original 100 will actually end up in permanent housing. And then only 12 will remain housed in that permanent housing if we look out several years. Now, if we look to Old Pueblo's low barrier housing, which essentially is a low barrier shelter on their way to that permanent housing, which means they can go into this housing if they have a pet, if they have a partner they want to bring with them, if they're struggling to stay sober, maybe they don't have ID immediately. That's something we would help them get, of course, but they probably don't have a way to pay, and all of these things that otherwise might typically be barriers. So we kind of push all those aside and get them housed as long as they can commit to being safe. They're not a danger to themselves or a danger to anybody else, at least for that current moment. And what we see there is 69 of those 100 will be permanently housed, and 52 will remain in that housing up to 2 years later. So big difference in outcomes when we look at, say, emergency shelter as an intervention versus the permanent housing, permanent supportive housing model. So we're going to spend most of our time talking about our tools and strategies for collaborating. What is kind of this university community cross partnership look like? And as I mentioned, we've been working together for more than a decade, so I'm sure that has helped tremendously. But these are sort of some tools that we've developed along the way. So just a bit more about the participating organizations, because I haven't mentioned our other partner yet. El Rio Health is a large federally qualified health system in Tucson, number of clinics across the city. They serve often a low-income population, certainly serve the homeless population. And then, of course, Old Pueblo, as Brandi mentioned, provides both housing and behavioral health services. And then our center's role in this project is really to provide the evaluation services, but also training and coaching around the evidence-based practices that are being utilized. And we'll speak to those in a little more detail in a minute here. So we refer to this program as the Street to Home program, or we may say SHP. We're all kind of caught up in our acronym land, right? So if you hear us say SHP, this is what we're referring to. So largely the program is around taking an integrated care team, which includes a family nurse practitioner, a health navigator, and a peer. So a peer being someone who is recently homeless, having that integrated care team go out into the street, try to engage with individuals who are chronically homeless or who maybe have some of these things going on that you see listed here, substance use disorders, some kind of mental health condition, a chronic health condition, and try to engage them in housing services. And bringing in those wraparound services that we talked about earlier, but with housing being the first priority. So what does this integrated care street outreach look like? I mentioned the 3 individuals that are involved in the outreach team, but they're really going out onto the street and trying to identify folks that aren't necessarily presenting in other settings. They may not be presenting in, say, a medical setting or a treatment setting, you know, a substance abuse treatment setting or other settings like that. So they're going out, you know, into the medians, they're going under the bridges, they're going out into the desert, into homeless encampments and other areas like that. I'm really trying to go directly to those people that we otherwise might find kind of hard to reach. And with that, they're conducting some very brief assessments that look at things like their mental health needs, any substance use that might be going on, and some health conditions that might make them more vulnerable. Okay, so one of the more critical tools that we're using that maybe really exemplifies our collaboration and what that looks like is our Services Standards Committee. So this is largely like a steering committee, we might say. All the participating organizations are represented on the committee. You know, it's not overly large, but it's not overly small. We want to keep it productive. I want to say there's about maybe 8 to 10 of us. So we have the CEO of the housing organization. We have the whole outreach team, those 3 individuals I mentioned. Myself as the principal investigator and the rest of our evaluation staff working on the project. And then leadership from the healthcare organization as well, including their grant manager. So everyone who kind of has a stake in the project, so to speak. And what we're looking to do is make sure that we are staying true to what we proposed in our original grant proposal, but then also what we outlined in our field guide, which sort of guides our work. That's a guide that we developed early on in the project once we were funded. We're also looking for fidelity to evidence-based practices, and I'll talk about how we do that in a minute. But then we're just kind of troubleshooting the day-to-day workflow issues, logistical issues, things that come up, and kind of trying to all hold each other accountable, making sure we don't get off track. So as you might imagine, when this program first started, we needed to meet more frequently. So we met once a month in year 1. Now we're just going into year 2, and we're meeting on a bi-monthly basis. And I'd imagine as we get further along in the later years of the 5-year project, we'll probably you know, meet on a quarterly basis once everything is sort of streamlined. But this is just a really helpful committee to guide our work and make sure that both the university and the community partners all have kind of a voice at the table, and that we're working together and really actively collaborating. Okay, so one of the tools, another tool I should say, that has been really useful in this collaboration is our program dashboard. And so the dashboard serves to kind of keep us accountable to our goals and objectives. So it's updated in real time as the clinical staff input client information. All of these tickers sort of move and can give us all you know, a chance at a glance to see where we are in terms of our progress. So whether that's the university, or whether that's the clinical staff, or whether that's the organizational leadership of the housing organization or the healthcare organization, we can all see pretty quickly, how are we doing? Where do we need to adjust? And I should mention, this wasn't a huge economic endeavor by any means. This was actually built in Excel, thanks to our graduate students and a lot of YouTube videos. So it wasn't an expensive you know, software package that we needed to purchase. Certainly those are out there if you didn't want to build something yourself, but I just wanted to encourage everyone, this is something you could build on your own in Excel. And this is our program flowchart, which maybe looks a little complicated. Here's sort of the second page of it. But the way that this is useful is it gets us all on the same page in terms of what is the path that a homeless individual takes through this program. And so we wanted to make sure that those of us on the university side could understand what's going on in the clinical world. And again, that path that the individual would take. And so what are the stop points and the start points and the stop gaps and all of those those things. And we want to kind of come together collaboratively and design this and make sure we were all on the same page in terms of what it looks like on a day-to-day basis. So I would highly recommend this kind of tool for any kind of university and community collaboration. It can be very helpful just to get a sense of, again, what does that workflow actually look like? And this is something we adapt in real time. Brandi and our colleague Trey frequently get together and make updates as needed. But this guides our work much like the Services Standards Committee and our field guide and so on. And then we engage in fidelity monitoring of those evidence-based practices that we identified in our initial grant proposal. So we want to ensure that we're staying true to those, that we didn't just throw them in the grant proposal, you know, in the spirit of getting funded, but that we really are using those practices that we say we use. And that's easier said than done, right, for all of us. So part of the way that the university is assisting the community partners is through this monitoring process. So we use validated instruments to measure fidelity to motivational interviewing, screening and brief intervention, the housing first model that I mentioned previously, and integrated care principles. If you're interested in fidelity tools for any of these, I can share these offline. All of the tools that we use are in the public domain. But this piece is really critical because it provides that feedback loop to the participating organizations. So the individual provider can get a really clear sense of, am I meeting the proficiency standards for this evidence-based practice? And maybe more importantly, if not, what modifications do I need to make? And so this is a nice role for the university to play in terms of mentoring and coaching and continued training and being able to kind of individualize that. So what you're seeing in the background here is one of our monitoring systems, MyMI. It is an online web portal for managing or monitoring rather fidelity to motivational interviewing. So the providers doing that street outreach, the providers working in the low barrier shelter can upload a work sample to the portal. Our motivational interviewing coaches can rate that sample with that validated tool and give the providers some feedback and coaching tips. And they can kind of see their progress over time as well. And last but not least is the peer guide. So as I mentioned earlier, the peer guide is someone who was recently homeless. And this role is really critical because they're familiar with the culture and the homeless population on the streets of Tucson. They can help liaise with that community. They can pinpoint individuals that we should be outreaching to, places to go to find folks and so on. And so their role is really essential in helping us bridge that gap to the homeless community. And I just want to mention as an aside, this individual, this is a paid position. So we had decided sort of early on that as the rest of us are all working for our organizations and being paid for our time, if they were going to have a seat at the table, they needed to be paid and compensated for that time as well. And I'm just glancing at the clock over here because I know our time is limited. So just a bit around our preliminary findings and sort of how things are going so far. If we look to our annual goals from our original proposal, what we're looking to do over this 5-year grant is outreach to about 200 individuals on the street each year, enroll 60 of them in the program, and then to permanently house 30 of them. So that doesn't mean just sheltering them, right? That means these individuals have moved from chronic homelessness into their own housing and have some financial means to sustain that housing. So we're looking to permanently house 150 people by the end of the grant. So year one, about 670 people were contacted on the street. 59 of them enrolled in the program and 29 were permanently housed. So just a person shy of our annual goal there, but just after the close of year one, we were able to meet those targets, and we anticipate continuing to meet these targets as we go along. And we won't go too much further into our findings, but some other things that might be interesting maybe to some of the clinical folks on the line is we did see a reduction in substance use and criminal activity, and we also saw an increase in income when we look at our 6-month follow-up. So I'm going to turn it over to Brandi, and she's going to speak to some client success stories and just kind of personalize this a bit for us. And just so you know, these individuals that she's going to speak about have provided their permission for us to sort of tell their story to you today.
Yes, and this is my favorite part. So first I'd like to tell you a little bit about Rose and Robert. They're a couple that came into our, they were actually living on the street near the Santa Cruz River for quite some time. And to speak on something that Adrienne mentioned in her presentation, they didn't want to be separated. So our low demand shelter was instrumental in them agreeing to come inside, because usually when you go into a shelter situation, the man goes one way and the woman goes another way, and they're separated, and couples aren't allowed to come in, and they had a pet as well. So they came into Tucson down to the public library and met our outreach team and our navigator and our nurse practitioners. And Rose suffers from Huntington's disease. So they were looking for some resources around that because her medications were being stolen on the street, and they were going through some other things. So they came down to our public library to see if they could find some resources around that, and ran into our team. They got a VI SPDAT assessment done. They scored high enough to get into our SHP program, Street to Home program. The next day, they were placed in our low demand shelter in a unit together. They weren't ever separated. They were able to take all of their things with them. Within a few days, they were both assessed by our family nurse practitioner. Rose was given her the medications that are necessary to keep her Huntington's under control. They began then working with El Rio to get her further assessed. Robert got some assessments done and got some medical treatment done. Robert says 45 days into this program, they were in their own apartment. So that's just the beauty of this. He says that her physical health, Rose's physical health is improving. He's able to care for her now because he actually has a shower and a toilet, and they have a place to sleep that's decent where their things aren't being stolen. They're not moving around constantly, so they're both able to rest. You know, he says you never rest when you're homeless because there's the chance that somebody's going to steal from you, you know, be abusive toward you. He says just having a functioning kitchen is a miracle. He says that this program was heaven sent and that he doesn't know where they'd be today without this program. So this is just an example of a couple that never had to be separated. She doesn't walk or speak very well, so he's her total caregiver. But had they gone into traditional shelter, she might have even gone into hospital while he went to regular shelter. And that's the reason why people stay homeless, because these shelters are sometimes a barrier. The impact that this has on the community is just really incredible. Can we go to the next slide, Adrienne? So 97% of eligible individuals were enrolled in state assistance programs, Medicaid, SNAP, TANF. Some people don't have any clue how to do this. So our team actually helps them do all of this, get enrolled in things, get their documents together, birth certificates, IDs, social security cards. And this program pays some of those expenses. So 100% of eligible individuals were provided with an initial health screening from our nurse practitioner, and many have gone on to get a PCP through El Rio and continue with those services long after their discharge from our program. Another success story that we have is Marianne. She is she actually left Maricopa County after having a rough breakup from an 8-year relationship. And she actually told us that she came here to die. That she was just in a downward spiral. By the time she got to Tucson, she just didn't have any more concern for her life. She said she met some of our team members out in the community. They did a VI SPDAT. She qualified for SHP. And immediately, after getting her in shelter, they began working on her warrants in Maricopa. Actually, our navigator drove her to Maricopa County to quash some of her warrants, to get her court stuff straightened out. We got her enrolled with our family nurse practitioner, got her going with her housing, got her into her housing, and she today is actually a peer with us. She goes out and tells her story to other people in the community that may be hopeless, as she was when she came to Tucson. So, and she's also been given an opportunity through El Rio to receive some dental work that she desperately needs. So this is just an example of, she says that her peer experience with Dee is awesome. She loves talking to the people, and she wants to go back to school for social services. So this is just some of the stories. I mean, I could sit here all day and tell you the success of this program. More impacts that I can give you is that 100% of eligible individuals received intensive navigation, including getting their documents, their IDs, getting rid of their warrants, enrolling in health services and behavioral health services. Mary Ann's actually receiving her mental health services through El Rio as well, so it's integrated. Exactly what we want to see in these programs. 83% of eligible individuals have an individualized recovery plan. Mary Ann has one, where it's constantly changing and moving and growing, and she's adding goals and completing goals. So programs like this just work. And these are just a couple of examples of how. I see that we have some questions here already, Adrienne.
Yeah, are they in the chat?
Yes.
Trying to find the chat here. Let's see here. Do you want to read them, Brandi? I'm sorry.
Yeah.
I've got the slides on the screen.
So the first one, Ben is asking, what barriers to adopting the housing first model do I see in Pima County? And I think for the most part, what we see is mainly with landlords. I mean, agencies have adopted this model all throughout, and you'll hear that all the time. It's housing first. It's housing first. So I think that landlords have a hard time wrapping their head around, hey, this person may be in full addiction and we're still putting them in housing. They don't have to have good behavior to get a house. And the reason why I think this is a barrier to the landlords, I'm not quite sure why it is, because we're not asking our non-case managed clients these same questions. So it's funny how when you get a program and somebody that's willing to, put them in housing and subsidize maybe even their housing, there's questions asked that wouldn't be asked of a normal tenant. So I think that's where we come in as strong advocates for those clients, Fair Tenant Act, those type of things. So I'm not sure if that answered your question, but I think landlords at this point is the biggest barrier that I see.
I might just add one thing, Brandi, and I know this is something Old Pueblo has struggled with historically, not so much anymore, but certainly some other organizations, is sometimes at the individual provider level, it's such a big paradigm shift to move to a housing first model. Because if they're coming from, say, transitional housing services, historically there have been many, we might say, regulations or rules and things that the person has to abide by. They might have a curfew, there might be a work requirement, they might have to pay a certain amount of their income, and all of those rules, they have to stay sober. And so for the individual provider that's maybe operated in that sort of services space for a long time, it's just a big shift. It can feel overly lenient or just uncomfortable, really. What's going to happen if we let things go like this? So I think there's that paradigm shift for the provider too. And then sometimes with folks with their own recovery experience as well, if they may be recovered in a different way and maybe one of those more structured models, that can be hard to let go of too, because they know how they were successful, and it's hard to maybe envision other folks being successful in a different way.
I think you're absolutely right there, Adrienne. I think we see that with some of our staff, our case management staff. You know, in the recovery communities, a lot of staff come from that lived lifestyle, that lived experience. So saying, oh, well, this person gets a house even though they're actively using, is hard for that staff person to sometimes embrace. So I think you're right there, and we just have to give some added training, and you know, your ASU comes into play there with the motivational interviewing and you know, an understanding of what that looks like to have a housing first model.
Awesome. So at this time too, you know, we do have about 6 more minutes. So if anyone want to ask any more questions before we go to our next presentation, I do have a question for you both. I know that you mentioned that you did have a grant that you wrote. So my question would be, you know, when you first applied to the grant, was there any shift that you guys did to year 2, year 3, as you guys saw the needs? Because I know sometimes when you write a grant, you feel like you have everything down, and then you start implementing it, and then you see a lot of different things that maybe you weren't considering at the time of writing the grant.
Do you want me to take this one, Brandi?
Yes.
Sure. So it's very interesting, and I don't think he would mind us saying this. He would have been one of our co-presenters today, but he's so busy putting out fires related to this virus. So Old Pueblo's CEO and myself and others were actively involved in writing the grant several years ago. And one thing I'm sure Brandi would attest to that he's very adamant about is sticking to the plan and having integrity around that original proposal. And so he's constantly in that Services Standards Committee function that I talked about. He's always bringing us back to what did we say we were going to do. And not that he's so inflexible that we don't make some adaptations as we go. We certainly need to. But he holds us all accountable to that, myself included, just to make sure that we really do what we promised the federal government and taxpayers that are funding our efforts, what we said we would do. So it's not that we haven't made adjustments, but we've tried as best we can to stay true to the model, at least, that we proposed, and the evidence-based practices that we proposed, particularly the Housing First model and the integrated care street outreach. We had a little bit of a drift for a while where we were doing a little bit of outreach at, say, soup kitchens, some other shelters, things like that. And then we kind of collected ourselves again and went, no, wait, we got to be out on the street where people might not otherwise be presenting. Let's find that person under a bridge who otherwise isn't making it into any kind of services. That's a great question. I don't, if you have anything to add, Brandi.
No, I think that sums it up. I think we did, for a minute, get off track about what true street outreach looks like. But of course, then we had the evaluators and Tom, our CEO, to bring us back on track and go with the fidelity of the grant. So.
And that's another piece around that university community collaboration, right? It's very easy for the evaluator sitting in their comfy university office to say what, you know, should or shouldn't be happening in the field. And it's completely another for the outreach team to come and say, whoa, 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 hold on, listen to all these barriers we're experiencing, and you got to get a sense of what it's like in the field. So we really try to use that Services Standards Committee to hear each other out and air those kinds of concerns.
I think that's really important. I have felt nothing but heard from the beginning on this grant. So, you know, Adrienne and everybody in the background, Terry, everybody, Tom, is there something that we need to change? Is there something that we need to tweak in this that we can meet you guys where you're at? So I think that's really important, is for everybody to be on the same page and to have that constant communication and bring everybody into the room that's involved, like not just the people sitting in a comfy office, but the people that are actually directly on the street doing the work. So I think that's crucial.
Any last minute questions for our presenters? No?
Before we run out of time, could I just point people to a couple of the resources quickly, Maria? Is that okay?
Yeah.
Great. Because I know you'll get so many slides with so many resources. I just want to let people know what a few of these are. Pathways Housing First. It is really kind of the founder of the Housing First model. There's a lot of great resources there. A few other Housing First resources here if you just want to learn more about that model itself. We also have an online training in the public domain in ASU's continuing professional education platform, the screening, brief intervention, or referral to treatment training, which is all about how do we screen people quickly, provide some motivation enhancing intervention, and then get them into whatever care that they need. Also the motivational interviewing portal that I mentioned. And then for any of you working in the substance abuse area, we have a pocket guide for medication-assisted treatment, medications to treat opioid use disorder and alcohol use disorder. And this is something that our street outreach team uses, but is also available to all of you. So I just wanted to point everyone to a few of those and what they are.